Fine. So thank you, Dr. Namrata and Dr. Santosh, for having me share the screen with stalwarts in ocular oncology. It's a pleasure to be here. So ophthalmic pathology has come a long way in its 6-decade-old history, right from describing the gross anatomy of the eye to guiding therapy. Now, with the use of modern tools such as molecular pathology, immunohistochemistry, and digital pathology, we pathologists don't stop at making a diagnosis now. We prognosticate tumors, and we also guide therapy. Now, a lot of things have been covered by previous speakers, and also it is not the right time to get into detailed pathology. So what I'm going to do is I'm going to take you through 4 different stories involving 7 different people. So let's go to story 1. Now the child at the top, he's a 7-year-old, while the one below him is a 5-year-old. Now both of them had proptosis because of an orbital mass. What do you think is the probable diagnosis? Okay, it could be a lymphoma, it could be a myeloid sarcoma, it could be a rhabdomyosarcoma. What would you do next? You would do an incision biopsy, correct? Boom, this is what happened. So what do you think it is now? Right, green color. Which tumor gives a green color?
Chlorella.
Yeah, correct. It's a granulocytic sarcoma. Now, this is what the incision biopsy showed. It's a malignant round cell tumor that was myeloperoxidase positive. So boom, your diagnosis is right. It's a granulocytic sarcoma. So what do you do next? You do a bone marrow evaluation, you do a peripheral smear evaluation. Now, these are characteristic OR-rod cells that you see in AML. Now, do you stop here? Not anymore. Now, let's take a look at this 7-year-old child. He had an 821 translocation, while the child on your right, he had an inversion of chromosome 3. Now, which of this child, both were given similar treatments. Now, what do you think happened to each of them? Now, the 7-year-old child who had translocation 821, he survived. The other one succumbed to disease. Why do you think this happened? Now, there are certain important prognostic factors in acute myeloid leukemia. The favorable ones are translocations involving chromosome 16, chromosome 821, and chromosome 1517. While there are a whole lot of them which have an unfavorable prognosis. Now, detection of these cytogenetic abnormalities plays a very important role in prognostication of granulocytic sarcoma. Similarly, genetic mutations such as presence of NPM1 and CBPA mutations have a favorable prognosis. On the contrary, mutations of FLT3, TP53, RUNX1, and ASXL1, they have unfavorable prognosis. Now, if FLT3 genetic mutations are present, you can always give protein kinase and tyrosine kinase inhibitors, and their prognosis significantly improves. Now let's come to the next story. This was a child who was 8 years old. He had this clinical picture because of an orbital mass. What do you think it is? Again, the same list of differential diagnoses: rhabdomyosarcoma, lymphoma, granulocytic sarcoma, Ewing sarcoma, PNET. This is the next patient. He was an 11-year-old child. He also had a similar mass. Now, both these patients had this clinical picture as a light microscopic picture. What do you think it looks like? Yes, it's a malignant small round cell tumor. Now, this tumor was desmin positive, myogenin positive, which makes it what? It makes it a rhabdomyosarcoma. But if you go back, it has a very alveolar pattern. So this makes it an alveolar rhabdomyosarcoma. Now, 60% of alveolar rhabdomyosarcomas, they have a PAX3 mutation, whereas 20% have a PAX7 FOXO1 mutation. Now, why is detection of these mutations important? Now, children with rhabdomyosarcoma who have a PAX3 FOXO1 mutation, they carry a poor prognosis as compared to those having a PAX7 mutations. In addition, the treatment protocols for these patients can also be different. Hence, just don't stop at diagnosis of it being a rhabdomyosarcoma embryonal or ARMS1. Go ahead, do cytogenetic analysis, and it will help you further better the prognosis in these patients. Story 3. Now, this lady was a 70-year-old lady who presented with proptosis in her left eye because of an orbital mass. The one on the right-hand side was a 55-year-old male who again had an orbital mass. Now, this is what the light microscopic picture showed. Large, angry-looking cells. They were CD20 positive, which makes it, yes, it makes it a diffuse large B-cell lymphoma. Now, diffuse large B-cell lymphoma is a very aggressive tumor, but if appropriate treatment is given at the right time, it has a great prognosis. Now, immunophenotypically, these DLBCLs have been classified as ABC and GCP types. I will not get into the details of them. Now, this lady, she had a ABC type of tumor, while the man had a GCP type of tumor. Now, why is this important? Now, ABC tumors, they have only 45% 5-year survival, whereas the GCB ones have a 90% 5-year survival. In addition, when we did cytogenetic analysis, we found that the lady had a c-MYC gene rearrangement. Now, what does that mean? Now, what you usually do is, in patients with DLBCL, you first do immunohistochemistry and detect whether there's a presence of c-MYC and BCL2 gene abnormalities. Now, if these are present, you do FISH analysis and see if there is only a MYC analysis, a MYC rearrangement, whether MYC rearrangement in presence of BCL2 or BCL6, or all three are present. This makes it a single hit, double hit, and a triple hit lymphoma. Now, why is this important? Let's go back to the previous slide. Now, the lady, she survived, while the man, he succumbed to disease. Now, triple hit lymphomas, they carry a poor prognosis as compared to the single hit lymphomas. They also have a greater chance of CNS involvement as compared to single hit lymphomas. Now, it has also been shown that single hit lymphomas, they respond to R-CHOP treatment, whereas the double hit and triple ones do not respond very well to R-CHOP treatments. In addition, they might need a R-EPOCH or a Codox-M treatment, which is given in Burkitt lymphomas. Hence, FISH and immunohistochemical analysis of DLBCLs is very important. Okay, let's get on to the next story. This was a 70-year-old lady who had this mass involving the orbit and lacrimal gland region. What do you think it is? It could be a NSAID. It could be a IgG4 related disease. Okay. Sorry?
Rosai-Dorfman?
Yes, it could be a Rosai-Dorfman disease as well. So basically, it could be a lymphoproliferative or a fibroinflammatory disease. Now, this is what an incision biopsy showed. There's a lot of fibrosis, there's a lot of inflammation, some eosinophils. So very difficult to make a diagnosis on light microscopy. Again, the same differential diagnosis. But when we did an ALK, the ALK came positive. Now, presence of this light microscopy in the presence of ALK positivity makes it what? It makes it an inflammatory myofibroblastic tumor. Now, why is detection of ALK important? Now, ALK rearrangements and overexpression is present in about 50% of IMTs. Now, why this helps is that ALK positive tumors, if they are given crizotinib, they respond very well, because there is a small fraction of IMTs which can metastasize, which can locally invade, which can recur. Hence, it is very important to do immunohistochemistry for ALK in these patients. Now, this is a PCR and a cytogenetic analysis which shows inversion of chromosome 2, which led to ALK overexpression. Okay, now the last part. Something that has turned out to be very important in this COVID times, digital pathology. Now, for us pathologists, this is something which is not very good. This is going to take the jobs away from us. So what is it? Is it a friend? Is it an enemy? I think it's a frenemy. Now, sitting in one place, someone else loads a slide somewhere in a scanner. I can always sit at home, make a diagnosis. Now, there are certain data points that are already fed into the computer will diagnose it. Now, there have been a lot of studies that have, been performed, whether the computer is superior or whether the humans are superior. What do you think it is? Any guess? Well, neither the computer is superior nor the human is superior. It is the combination of the computer and the human that is more superior in making a diagnosis. So digital pathology with human mind is always the best. So with this, I conclude, and I think I pass it to Vikas. Thank you, Dr. Santosh, once again.
Thank you.